Hello. Today we will talk about the pregnancy and inherited blood disorders. Pregnancy, as we know, is hypercoagulable state, and the thrombophilia, also the tendency to thrombosis, has been developed rapidly and has been linked to many aspects of pregnancy. And we know that the severe pregnancy complications, such as a severe preeclampsia, intrauterine growth retardation, placental abruption, and the stillbirth, has been shown to be associated with thrombophilia. And also recurrent miscarriage has been associated with thrombophilia, especially with antiphospholipid syndrome. And finally, thromboembolism in pregnancy is and non-pregnant state is linked to thrombophilia. And in this lecture, we will review all the aspects of thrombophilia in pregnancy and also all the prophylactic and therapeutic implications. Let's have a look to the discussion objects. And in the present lecture, we'll discuss and make the review of the more common types of thrombophilia in pregnancy, review the recommendations for management of thrombophilia in pregnancy, peculiarities of pregnancy in patients with beta thalassemia, and thrombophilia and adverse pregnancy outcomes. Thrombophilia is defined as any inherited or acquired disorder associated with an increased risk for thrombosis. And there are three main types of thrombophilia. It's inherited thrombophilia, it's factor 3 protein S, factor 5 LADA mutation, prothrombin gene mutation, acquired thrombophilia, mostly it's antiphospholipid syndrome, antithrombin, protein S, protein C deficiency, and also we can observe mixed type of thrombophilia. Thrombophilias are inherited or acquired conditions which predispose an individual to thromboembolism. Deficiencies of protein S and C and antithrombin are rare, and each of them is found in about 3% of patients with thrombosis. Three important inherited thrombophilia were discovered which are responsible of the majority of thromboembolic events in patients with adverse, no apparent risk for the thrombosis. And the risk of venous thromboembolism, as we know, associated with an acquired and inherited thrombophilia is amplified by other risk factors. And for example, the post-surgical state and immobilization. Recent evidence suggests that the risk of maternal venous thrombosis in cases with underlying thrombophilia is substantially increased, and the risk of venous thromboembolism in pregnant women may be further amplified by the type of underlying genetic predisposition. And also, very severe obstetric complications such as preeclampsia, abruptia placenta, intrauterine growth restriction, and intrauterine fetal death greatly contribute to maternal and fetal morbidity and mortality. And all these causes mostly are unknown, but we know, but mostly all of them may be associated with abnormal placental vascularization and disturbance of hemostasis, leading to inadequate maternal and fetal circulation. What is the incidence of common hematological problems in pregnancy? It's mostly iron deficiency anemia is accounted for 10% of all the pregnancies. Vitamin B12 deficiency in 5%, folate deficiency 5%, hemoglobinopathies and thalassemias are accounted to 5% of patients, sickle cell anemia, alpha thalassemia, beta thalassemia, thrombocytopenia, von Willebrand disease, and also hemophilia. And these pathologies are the most common hematological problems during the pregnancy. What about the inherited thrombophilia? The incidence of inherited thrombophilia is about 15 to 20%. Enhanced thrombogenic potential during the pregnancy causes for about 50 to 80% of all maternal thromboembolic events. And venous thromboembolism complicates it approximately 1 in 500 to 1,000 pregnancies. A high rate of protein S deficiency, hypercystinemia, was found in the most patients with thrombophilias. What is the characteristic of inherited thrombophilia? Inherited thrombophilia is a group of genetic conditions that increases the chance of developing abnormal clots in the veins or in the arteries. Common sites for venous thrombosis include the veins deep inside the body and the veins of the lungs as the thromboembolism. The most common inherited thrombophilias are frequently caused by mutation in the gene F5 and F2. F5 laden mutation is found in 3% of European and less than 1% of African Americans. F factor 5 laden mutation is found in 20% of individuals with a history of venous thromboembolism. Factor 2 mutations or prothrombin is found in 6% of individuals with a history of venous thromboembolism. And since the rate of venous and arterial thrombosis and of placental thrombosis in pregnancy complications is not essential different between the ethnic groups and races, it may be that other thromboemphilias as yet unknown play a role in the development of these states. For example, the factor 5 laden mutation is the highly prevalent among the Caucasian population, and the prevalence of this pathology is ranging from 10 to 15% in Sweden, 4 to 8% in Central Europe, and 2 in the South and 5 in the United States. The statistics for the incidence of factor 5 laden mutation in different areas of the world. The mutation is almost non-existent in Asia, Japan, Africa, and South Africa. And preeclampsia is a multigenic disease, and there are important differences in the prognosis and the management between the late mild preeclampsia and early onset of the severity of this disease. What are the main risks of inherited thrombophilia for the pregnancy? These are protein C deficiency, protein S deficiency, homozygosity for factor 5 laden mutation, homozygosity for PTG2021-0A mutation, and combined heterozygosity. What kind of complications we can observe in patients with thrombophilia? Mostly it's a preeclampsia, pregnancy-induced and aggravated hypertension, excess protein in the urine, and that the preeclampsia is the pathological condition that is associated with pregnancy. And preeclampsia usually develops after 20 weeks of gestation, and preeclampsia may lead to the very severe complications and even to increased risk for the maternal and fetal morbidity and mortality. Preeclampsia is the state that associated with abnormal placentation, and the pathogenic mechanism of this pathological condition is associated with abnormal vascularization and abnormal coagulopathy. And it will lead to the generalization of this pathological condition all over the organism of pregnant women and may lead to the different complications that associated with them ischemia in different organs and systems. And the clinical signs of preeclampsia is the elevated blood pressure, and depending on the severity of preeclampsia, the blood pressure may vary from 140 millimeters hydrargyrum and more in the systolic, and more than 90 millimeter hydrargyrum in diastolic blood pressure. Also proteinuria and edema of the lower extremities, and in severe cases, edema of the whole body. And the patients with preeclampsia, they usually have intrauterine growth restriction of the fetus because of the pure nutrition and pure placentation. Intrauterine growth retardation demonstrate that the fetus is small for its gestational age, and this is accounted for 10% percentile. Placental abruption is also one of the complications of pregnancy in patients with thromboembolism, and placental abruption, it's a premature separation of the normally located placenta and before the term of pregnancy and before the prior to the delivery, and it's very life-threatening condition for both mother and the fetus, because placental abruption, depending on the degree and the area of separation, may lead to the severe hemorrhage and even may lead to the hemorrhagic shock of pregnant, and also may be associated with the acute hypoxia of the fetus or even intrauterine demise of the fetus. And what kind of abnormalities of the placenta we can observe in patients with thrombophilia? Placenta is a vascular organ, and it develops, finish its development to the 20 weeks of gestation. And it develops from the chorion, and the placenta, it's a vascular organ, and it is the main organ of the pregnancy because all the nutrition elements and gas transport happens inside the placenta. And without normal placenta, there is no possibility for the normal growth and development of the fetus inside the uterine cavity during the pregnancy. And the thrombophilias can cause clots in the placenta, and these clots, of course, will lead to the restriction of the normal physiological area, healthy area of the placental for the adequate gas transport and nutritional elements transport, and also metabolism of the fetus. And placental vascular complications may lead to the fetal loss or miscarriages, preeclampsia, intrauterine growth retardation, and also placental abruption. And as we see, all these pathological conditions are associated with the thrombophilias and may lead to the very serious complications of pregnancy. How can we treat it? What is the management for the treatment of these pathological conditions as the thrombophilias? And usually the treatment is established during the pregnancy and antepartum. And there are some medicines that are used during the pregnancy, and usually it's the low molecular heparins, and we use enoxaparin in 40 milligrams or 1 milligram on kilogram in dosage every 12 hours. And we also use prophylactic and therapeutic dose of these medicines all during all the pregnancy. You can see on the slide the dosage and the regimen of these low molecular heparins in therapeutic and prophylactic doses that we use during the pregnancy and during the postpartum period. One of the most common types of thrombophilias is antiphospholipid syndrome. What is antiphospholipid syndrome? Antiphospholipid syndrome, it's a condition in which autoimmune or either isolated, it may be autoimmune or either isolated condition, and it may complicate the pregnancy. Also, it may be autoimmune or isolated for or as a part of other immune disorders. It involves antibodies to proteins that bind phospholipids and prolongs phospholipid-dependent assays, antibodies to cardiolipin and beta-2 glycoprotein 1. The clinical manifestation of antiphospholipid syndrome include deep venous thrombosis and preeclampsia, coronary or peripheral arterial thrombosis, cardiovascular or retinal vessels thrombosis, and pregnancy morbidity. Women with no history of thrombosis or prior fetal loss who are found to have antiphospholipid syndrome during a first pregnancy do not need prophylactic therapy. Women with antiphospholipid syndrome who have had prior thrombosis, whether or not are associated with pregnancy, must receive thromboprophylactic therapy throughout the pregnancy and the postpartum period. This diagnosis of antiphospholipid syndrome is based on clinical and laboratory criteria, and there are problems with each set of criteria. It's based on analysis on weaker level studies, and clinical criteria are also controversial. Multiple losses do not always account for other etiologies. During the pregnancy, as I told you, the risk of venous thromboembolism during the pregnancy and postpartum period increases and is accounted for about 5 to 12%. In non-pregnant state, venous thromboembolism, arterial thrombosis, stroke, or thrombocytopenia. Pregnancy and pregnancy loss, preeclampsia, and intrauterine growth restriction. The treatment of an acute venous thrombosis in patients with antiphospholipid syndrome carrier is similar to that indicated for the woman with other types of thrombophilia. However, in our opinion, there are differences in the maintained doses and duration of prophylactic therapy required. In women with antiphospholipid syndrome, we tend to administer higher doses of low molecular heparins depending on the severity of the thromboembolic event, the history of previous thromboembolic event, and the titer of the circulating antibodies. Any of the labs must be verified with a repeat testing of 12 weeks apart when the titer of antibodies is increased. Also, along with this, we made the detection of the lupus anticoagulant, and in patients with antiphospholipid syndrome, this lupus anticoagulant is always positive. Anticardiolipin follows also by elevated immunoglobulin M and G, also beta-2 glycoprotein 1AB of immunoglobulin and immunoglobulin G more than 99%. What are the clinical criteria for the antiphospholipid syndrome? It's a vascular thrombosis, arterial or venous, any size of the vessels may be affected in the patient with antiphospholipid syndrome. Increased placental pregnancy morbidity due to abnormal placentation and coagulopathy lead to the increased morbidity at the pregnancy and also to the pregnancy loss. Unexplained fetal death at or beyond 10 weeks of gestation, and it's one of the most common causes for recurrent abortions. And that's why if some patients have several subsequent abortions, we made the diagnosis recurrent abortion, and it's one of the most common causes for these recurrent abortions. Unexplained fetal losses increases threefold times with and it's exceed the pathologies, the development of the fetuses with chromosomal abnormalities. They are excluded. And antiphospholipid syndrome also increases the risk for preterm delivery. And usually spontaneous labor activity may start before the 34 weeks of gestation. And usually we can observe this pathological condition in patients with preeclampsia or placental insufficiency. And of course, it may follow by the intrauterine growth restriction of the fetus. Antibodies to negatively charge phospholipids. It's phosphatic acid, phosphatidylserine, phosphatidylglycerol, phosphatidyldenolistol, antiphospholipid most commonly studied. Inhibition of trophoblast development or invasion through binding of syncytial trophoblast and decreased human chorionic gonadotropin levels. Heparin shown to decrease binding of antiphospholipins and to syncytial trophoblast. The testing is not standardized, and studies lacking to allow for inclusion in the antiphospholipid syndrome laboratory criteria. Detection of immunoglobulin A, anticardiolipin, and beta-2 glycoprotein 1 may be useful with African Americans obstetrical antiphospholipid syndrome. In one research, Lee showed that immunoglobulin A type ACL more common in pregnancy loss when atypical antiphospholipid syndrome are normal. It can be considered in patients with negative antiphospholipid syndrome laboratory parameters and poor pregnancy outcomes. What are the clinical dilemmas in the patient with thrombophilia during the pregnancy? The most important issue is the planning and the plan ahead. Consider genetic studies for any loss when products of conception is available to find out if there was a thrombophilia in the fetus, because sometimes fetus is also guilty in the development of coagulopathies during the pregnancy, because sometimes the fetus has inherited thrombophilias and it will affect the duration of the normal pregnancy and the developing of pathological coagulopathy in the maternal organism. We should make the testing after one miscarriage that happened less than 10 weeks of gestation in patients with a normal genetic testing. And if the patient have the multiple losses, patient desires heparin therapy. What we do in this condition? We should make the uterine and hormonal evaluation, and if we find no pathology in this, and we will find any traces of the thrombophilias, then we may prescribe the low-dose heparin during the pregnancy to prevent this severe obstetric complication. The summary: thrombophilias can occur as inherited or acquired, or in some cases as both types. Management during the pregnancy and postpartum may depend on time of thrombophilia and the history involved. Both types of thrombophilia should be part of the workup of venous thromboembolism, inherited and acquired. And it is important to know that antiphospholipid syndrome criteria, but also to be aware of additional studies that the patient may request, so testing, treatment options, and in any case, all the findings may be discussed. One of the most common pathologies that linked with the coagulopathies and abnormal vascularization during the pregnancy, it's thalassemia. As we know, the beta thalassemia is one of the most common genetic disorders, and our country, Azerbaijan, is one of the endemic zones for the thalassemia. And the incidence of thalassemia in Azerbaijan, it's very high, and it increases, and the problem of thalassemia is involved into the governmental program of our country. Thalassemia, let's introduce some numbers and epidemiology of thalassemia. Thalassemia affects approximately 4.4 of every 10,000 live births throughout the world. Approximately 7% of the world population has a variation of the alpha or beta part of hemoglobin molecule. Some of them are silent carriers. 1.7% of the global population has signs of the gene mutation known as thalassemia trait. The number of children born with thalassemia in Azerbaijan is more than 200 annually. It's a very great number. It is more prevalent in Sheki, Ağdaş, Masallı, Sabirabad, Oğuz, and the Göçay. There are two types of thalassemia, alpha and beta thalassemia. What are the clinical symptoms for the thalassemia? It's first of all, it's anemia, pale or yellow skin, jaundice, hepatosplenomegaly, dark urine, feeling tired, feeling fatigue, weak or out of breath, facial bone deformity, growth retardation, delayed puberty, primary and secondary amenorrhea. These patients with amenorrhea, they characterize with the delay in the anthropometric parameters, and usually they have the small, high, low body mass, and they usually have asthenic body structure, and all these linked to the problems with insufficient blood supply in all the organism. What kind of complication can we observe in patients with beta thalassemia? First of all, it's a preterm birth related to poor maternal condition. Fetal intrauterine growth restriction, also due to maternal anemia. Placental ischemic disease, high incidence of gestational hypertension, diabetes, urinary tract infections. They are also very frequent during the pregnancy in patients with beta thalassemia. Renal and gallbladder stones, increased risk for thrombosis due to chronic hypercoagulable state, and 30 to 50% increased risk for maternal mortality due to cardiac cirrhosis, because these patients, they get the treatment with the iron, and usually one of the complications of this therapy is the cirrhosis, and increased cardiac cirrhosis may lead to the increased rate of maternal mortality. Along with the blood transfusion and the ferrum medicines, we also prescribe folic acid, vitamin D, vitamin C, and other complex of the medicines. At the end, what type of adverse pregnancy outcomes we can observe in patients with thrombophilia and thalassemia and other blood disorders? First of all, it's a vasculopathy and secondary thrombosis from how hypercoagulability may result in inadequate perfusion of the intervillous space, preeclampsia, placental infarcts, intrauterine growth restriction, placental abruption, and even intrauterine fetal demise. The non-thrombotic nature of the placental vascular lesions and the increased thrombotic risk are associated with the existence of thrombophilia strongly suggest a relationship between inherited and acquired thrombophilia and severe obstetric complication. That's why we should find out all these conditions before the pregnancy and make the prevention of this condition. And we cannot treat this condition, we can treat their complications and adverse outcomes, but we can make the prevention of this adverse pregnancy outcomes that are associated with hypercoagulability in the patient with thrombophilias. And the main treatment option is the low-dose heparin that we prescribe with the beginning of the pregnancy or from the 16 weeks of pregnancy. And we continue this regimen during the pregnancy and in postpartum period. And the quote of the day at the end of our lecture, the quote of the Great Rumi. Life is a balance between holding on and letting go. Thank you for your attention.